Today we shall learn how managing respiratory distress optimally helps prevent retinopathy of prematurity. What we will do is, we will primarily focus on how management of respiratory distress affects the development of retinopathy of prematurity, and then how to prevent retinopathy of prematurity by optimal management of respiratory distress. Let us understand the potential areas where inappropriate management of a neonate with respiratory distress places him at a higher risk for developing ROP. At birth, during resuscitation, if the baby receives oxygen which is not monitored using a pulse oximeter, or if the baby is given unblended 100% oxygen, he is exposed to more oxygen than required, and hence he is at a higher risk for developing retinopathy of prematurity. Let us see during transport. Well, if during transport of a baby from a center which is different from his place of birth, if the baby becomes hypothermic or he is hypoxic, or worse still, if he fluctuates between hyperoxia and hypoxia, this affects the retinal vascularity, predisposing the infant to reperfusion injury and places him at a higher risk of developing retinopathy of prematurity. In the neonatal unit, if the baby receives oxygen which is unmonitored, or the baby remains hyperoxic while he is on oxygen therapy, he is at a higher risk to develop retinopathy of prematurity. It needs to be understood that babies who remain hypoxic and then become hyperoxic tend to have severer damage to the vulnerable retinal vasculature. And it goes without saying that if surfactant or respiratory support in the form of CPAP or mechanical ventilation are suboptimal, or worse still, if they are instituted late, then the baby continues to be exposed to higher oxygen and is more liable to develop severe ROP. Let us now focus on how to mitigate the ill effects of issues that we discussed previously. So, let us see at birth, if the baby requires oxygen, then it has to be blended and the neonate must be monitored using a pulse oximeter to ensure that the minute specific saturation targets are not exceeded in the initial few minutes. Thereafter, if the neonate requires oxygen, it should be ensured that the baby is neither hypoxic nor hypersaturating, with the oxygen saturation being maintained well within the normal range of 90 to 95%. During transport, it will be ideal that the baby's temperature is maintained either over a warming mattress or preferably in skin to skin contact. The neonate should receive adequate amount of fluid or feeds depending on his clinical condition, and the saturation must be maintained between 90 and 95%. So, to prevent ROP, it is imperative that all babies on respiratory support, including those on oxygen, have their oxygenation monitored continuously using a pulse oximeter. The saturation targets should be set and the alarms must be respected to ensure that the saturation remains between 90 and 95%. For the neonates requiring surfactant and respiratory support, it must be ensured that the total duration of ventilation, the days on oxygen therapy, as well as episodes of hyperoxia and hypoxia are minimized to the best possible. It is very important that while the neonate is being managed for his respiratory ailment, he should not pick up infection from the unit during his stay, which really means that the asepsis should be meticulously maintained. However, if there is any neonate with infection, he should be appropriately and adequately treated. So, all these measures put together will certainly help to reduce the incidence as well as the severity of ROP, if not completely prevent it. So, friends, to summarize, if we optimally manage the respiratory distress using CPAP and surfactant, which is given early and appropriately, along with meticulous oxygen therapy, using blended oxygen and monitoring of oxygenation using pulse oximetry, this all put together will help to reduce the severity as well as the incidence of retinopathy of prematurity. Thank you.